So we're going to continue on with bowel health and also talk about urine elimination. So I know I've talked a little bit about laxatives. There's different categories that you will need to know. So there's stool softeners like X-Lax, Senecote, Senazol, Dulcolax. There's also another category referred to as cathartics. Their objective is to promote peristalsis. So this is like magnesium citrate, magnesium sulfate. Laxative overuse. So chronic use of laxatives can cause weakening of the bowels, expected from like distension of the abdomen, from feces, resulting in the development of chronic constipation. So essentially, overuse can in turn have the opposite intended effect. So ostomies. So there are some bowel disorders that prevent the normal elimination of stool from the body. Body diversions through ostomies are temporary or permanent openings, also known as stomas, that are surgically created in the abdominal wall to allow fecal matter to pass. So ostomies are created in either the large intestine or small intestine. They end in the colostomies end in the colon, and ileostomies end in the ileum. So end stomas are usually a result of colorectal cancer or another type of bowel disease. There are loop colostomies, which help resolve a medical emergency, and those are temporary. So in a loop colostomy, a loop of bowel is supported in the abdomen with a proximal stoma draining stool and a distal stoma draining mucus. It's usually constructed in the transverse colon. Double barrel colostomies, wow, that's a mouthful, consist of two abdominal stomas, one proximal and one distal. The proximal stoma drains stool, and the distal stoma leads to the inactive part of the intestine. After the injured area of the intestine heals, the colostomy is often reversed by reattaching the two ends. So urine elimination. It's really important to know this because there's going to be a lot of situations where patients are going to require strict what's known as like I&O monitoring, so input and output. Heart failure is a big one that you will be required to see if a patient is producing adequate urine, or kidney failure, that's another one. And heart failure and kidney failure often come in tandem, or one develops later on. Usually like heart failure will cause kidney failure. So urinary diversions are the surgical creation of a stoma, either temporary or permanent, for the drainage of urine. Surgeons create these for clients who have bladder cancer or an injury. Urinary diversions have many similarities to bowel diversions. Clients who have urinary diversions often share similar body image concerns as those who have bowel diversions. And that point goes, or it's important to think about what we discuss with like therapeutic communication, because really with any patient that has a procedure that's really physically changing them, they can definitely have an identity shift, and it can cause a lot of self-esteem issues. So it's definitely useful to be aware of that when communicating with them. So diversions are either continent, so these are controlled elimination of urine, or incontinent, with urine draining continuously without control. Continent diversions have a reservoir in the abdomen that allows clients to control the elimination of urine. Not to get too far ahead, but for example, patients that have certain spinal cord injuries, they might not be able to control their bladder. So it really depends on the type of injury and the patient's level of consciousness and the injury. So a uridostomy is an incontinent urinary diversion for which the surgeon attaches one or both ureters via a stoma to the surface of the abdominal wall. A nephrostomy is also incontinent urinary diversion for which the surgeon attaches a tube from the renal pelvis via a stoma to the surface of the abdominal wall. It's helpful to be aware of a couple of medications that change urine and stool color because it can often freak patients out if they don't know about it or weren't expecting it. So phenazopyridine can turn urine orange or red. Amitriptyline can be green or blue. Levodopa can just have much darker urine than expected. And iron can come out black. So remember, just as a general rule, in terms of urine output, you're striving for at least 30 milliliters an hour. And if a patient is producing less than that for more than 2 hours, that's a big concern and needs to be escalated.